Wang live at us from Greenwich, and he's going to talk about vein grafts doing PCI.
Can you guys hear me?
Yes.
Okay, perfect. We can get started, Jen, right?
Yeah, go ahead.
Okay, perfect. So thanks everyone for attending today's session. Sorry I couldn't be there in person. Got some clinical duties at Greenwich. If I happen to be taking a phone call or stuff like that, that's because of that. So hopefully everything will be pretty quiet. So today we'll talk about bypass graft intervention, specifically focusing on vein graft intervention. So the learning objectives for today, we will first talk a little bit about bypass graph angiography, and then we'll start kind of diving into the data on bypass graph pathophysiology and attrition rate. And we will talk a little bit about redo cabbage versus PCI, either of the vein graft versus native vessel, and we'll talk about some of the data surrounding that. And then lastly, we'll talk about some techniques and strategies that should be considered with vein graft PCI, focusing our time specifically on sort of bare metal stent versus drug-eluting stent. And we'll talk also a little bit about embolic protection device. So first things first, it's knowledge of the bypass graft anatomy is critical for optimizing cardiac cath because our goal is really to reduce contrast and fluoroscopy time. As you're aware, like not all the time, not all the grafts are easy to be located, and they can be located in pretty unpredictable locations, especially if we're missing the surgeon's operating report from years ago. And sometimes just looking for them requires multiple contrast injections, catheter manipulation, which further increases radiation exposure and risk to the patient. So this figure shows the usual site of insertion of vein grafts to coronary arteries. The vein graft to the RCA, let me just use my pointer. So the vein graft to the RCA is usually most anterior and located at the lowest point in the aorta, whereas grafts to the branch of the left coronary artery are usually inserted in a more kind of progressively higher position in a more posterolateral position. So like native vessel diagnostic angiography, we tend to use LAO to view vein grafts to the right, and then we often use straight AP projection to view vein grafts to the left. Although sometimes if you, depending on the position of the left-sided vein graft, sometimes an RAO view would be beneficial because it's more orthogonal to the insertion of the vein graft. So yep. If you guys have any questions, feel free to speak up. So in terms of diagnostic catheters, graft to the right is usually downward pointing and therefore requires a downward pointing catheter, whereas graft to the left is usually upward pointing and requires upward pointing catheter. So for vein grafts to the right, I usually starts with a JR catheter, then an RCB perhaps, with a low threshold to use a multi-purpose, because oftentimes it's a straight shot, given sort of the downward position of the SVG to the RCA. And then for vein grafts to the left, I usually start with a JR because it's kind of readily available, and you can try it, but sometimes you might have to upgrade to an LCB or AL1 or even AL2. Other catheters I probably we really kind of see in kind of less rare is if we go kind of for whatever reason we go through right radial artery and we need to engage a lima. Sometimes we use a catheter called the Simmons catheter, which actually has that kind of a pretty dramatic bend in a long arm that can kind of get you into the left subclavian, and we can wire from there and engage it with an IMA or a JR catheter. I wish I could show a picture here. I meant to copy and paste one onto this slide.
Kedong, I would
So
just add the IM catheter, right? I mean, I use that as my first go-to. I get the Lima with it, and then I use it for the native right, the right graft if I can, and whatever other vein grafts. So I would just add that as well. I think it's kind of underutilized in our lab here, but I always start off with an IM catheter.
yeah, that works too. Yeah, we try to use as little catheter exchanges as possible. So, definitely. And I remember certain cases I did with Fusion, we were able to engage all the grafts with the iron catheters. So this is a slide which I took directly from Elias Hannes's YouTube lecture. He's actually an interventional cardiologist based off of Iowa City, and he put up many YouTube lectures that he posts online for free, and talking just about kind of the tips and techniques of interventional cardiology. And this is his published book, um, Practical Cardiovascular Medicine. So basically, there's kind of 2 points he makes with regard to graft patency. So obviously, when you take angiograms, the primary interest is, if you want to know if the graft is patent or occluded, because sometimes grafts themselves are challenging to engage. So when you're shooting native coronary arteries, two concept which is pretty useful is competitive flow uh, and the presence of collaterals. So competitive flow is kind of pretty self-explanatory, and if you see that in any of the native vessels, then it directly indicates that it has a graft and that graft is patent. Um, one caveat is that the absence of competitive flow does not necessarily mean that the graph is occluded. So, for example, in this diagram that he used, the SVG is grafted to OM2, which is proximally occluded here. So when you shoot the native arteries, you might not necessarily see competitive flow because of occlusion here in the proximal OM2, when in fact the SVG is actually patent. Um, so in terms of collaterals, obviously, if there's a territory that's kind of missing vascular supply, there's one of three possibilities really. It's either supplied by the native vessel, it's supplied by collaterals, or it's supplied by a graft. And if the native vessel is occluded and there's no collaterals, then there's probably a graft that you should look for. Whereas, if there's presence of large collaterals to that particular territory, it might be possible that the graft itself is occluded. Obviously, these are kind of dependent on the timeline at which, the patient was grafted. And there's other, considerations such as that. So, we talked a little bit about anatomy. So I just kind of would like to start with the background before talking about a few trials and datas that I will present after this. So this is NCDR number, and this was a number a few years ago. And based on the NCDR registry, 17% of all PCIs are performed in patients with prior cabbage. Might be a little bit perhaps higher than what we see in the cath lab, but I don't think the numbers are significantly off. So of those PCIs that were performed, of those 17.5%, 11% are performed in native vessel coronary arteries, and then 6% are performed in venous grafts, whereas only 0.4% are performed arterial graft, obviously because usually those are patent, and even less performed in both SVG and arterial graft during index hospitalization at 0.04%. So vein grafts are different than native vessels or even arterial grafts in general. We all know that the attrition rate of vein graft is pretty high. Probably the most quoted number is about 50% are occluded 10 years post-cabbage. And that's because of different patient-specific factors and also factors specific to vein grafts themselves. Most of these patients have more comorbidities and these disease burden in general, so they're predisposed to higher rate of atherosclerosis. Vein grafts themselves in general have larger plaque volume, and they're often characterized by soft, friable cholesterol. And these degenerate SVG lesions tend to have poorly developed fibrous calf. And I'll show you a histological slide in a little bit more. And then earlier sort of older trials have shown that both in vivo and vitro studies, there's higher level platelet activations in vein grafts compared to arterial grafts or native vessels. Okay, so this is kind of the largest study sort of charting the natural history of vein grafts and IMAs. It looked at about 12,000 patients who underwent cabbage between the years of 1983 and 1988 in 13 participating VA hospitals. You know, this was data extrapolated from two other trials that were designed to determine the effect of antiplatelet agents on graft patency. In those trials, patients underwent cardiac cath at 1 week, and then at 1 year, 3 years, 6 and 10 years after cabbage. If graft was patent, if it's not 100% stenosed. So basically, graft patency was defined by whether or not it was 100% occluded. So this chart shows that on a per graft basis, the author found that after about 10 years post-cabbage, 39% of vein grafts are occluded and 15% of IMA grafts are occluded. So higher rate in the vein graft compared to the IMA grafts. Interestingly, if the vein graft was patent at 1 week, then the occlusion rate was lower. It lowered by about 5%. So the occlusion rate was 34% compared to 39%. If it was patent by 1 week. And the same with IMA graft as well. There was higher patency 10 years out if the IMA was able to survive 1 week out from the cabbage procedure. So some of the additional results from the study, you know, this was kind of an old study, so oftentimes an SVG graft was used to bypass an LAD lesion, and the author found that SVG to the LAD do better than SVG to the other vessels. And, you know, a target vessel with a diameter greater than 2.0 millimeters was associated with better graft patency. Other than that, I want to mention that it's interesting to study because the occlusion rates are slightly lower than sort of the 50% occlusion rate that we cite for SVG grafts sometimes. And so that 50% number came from even earlier observational studies in the 1970s. So in a sense, when this study came out, it was a more contemporary study using sort of the most contemporary medical treatment and surgical techniques at the time. So this is a kind of a nice slide. It highlights the accelerated natural history of atherosclerosis in a vein graft. So the progression from A to F. So within the first year of grafting, there's this concept of arterialization of the vein graft that's characterized by fibrointimal thickening. And, you know, following that, there's foam cell accumulation. So when the smooth muscle cells in the intima media migrates into the intima, there is thickening of this intima here, and we can see the accumulation of foam cells. Between the first and third year, there's formation of a lipid core, followed by subsequent hemorrhage into the lipid core and progression in the size of this lipid core. And then when you get an acute rupture of the fibrous cap, then you get an acute occlusion of this particular vessel. So this process can vary, you know, with different rates and different characteristics depending on where in the vein graft you're talking about. So generally, at the site of distal anastomosis, fibrointimal growth is more commonly observed than neoatherosclerosis. And the reverse is true for aortoosteal uh, location, where you can see more atherosclerosis than fibrointimal growth. So this is kind of the framework that I use when I think about graft failure. So, I kind of divide it by timeline. So between 1 week and 1 month, this is like the very earliest graft failure. It's commonly due to thrombotic closure, usually at the site of anastomosis as a result of endothelial injury and release of sort of inflammatory cytokine during surgery. There's also technical aspects about these failures that includes conduit size mismatch, mechanical forces, and reperfusion injury. So after about 1 month, if the graft is still patent, then it's subjected to the threat of neointimal hyperplasia. And in a sense, it's sort of a maladaptive response. It's adapted in the sense that, it's undergoing the process of arterialization to be able to withstand the pressures that's necessary. But at the same time, through the process of sort of neointimal hyperplasia, you get stenosis of the vein grafts. And then after 1 year, there's neoatherosclerosis. I here is that there's an important process that's specific to vein graft, and earlier studies have demonstrated that in general, the smooth muscle cells in the vein grafts tend to be more proliferative, and they tend to be more subjected to migrations into the intima as compared to arterial graft. There's also other studies that shows that the extracellular matrix of Saphenous vein grafts are more rich and are therefore more prone to sort of higher expressions of protein that facilitate migration. And so there's quite an extensive literature on that, which we won't really delve into, but it's kind of a rich area of study. So despite sort of the biological shortcoming of vein grafts, surgeons are in general hesitant to perform repeat CABG because oftentimes it is associated with a significantly higher rate of sort of perioperative mortality when compared to PCI. So the Awesome trial, this trial is called the Awesome trial. It was kind of the first randomized trial comparing CABG with PCI in patients who had prior CABG. So importantly, this is a randomized trial. And the study design of it is such that patients are divided into either randomized group, decision-directed group, or patient choice group. So what they did was they had two cath lab operators. And for patients who presented with sort of clinically relevant medically refractory ischemia, they cath these patients. And of those patients, a few of them were felt to be amenable to revascularization, either by PCI or CABG. And they divide that group randomly into either CABG or PCI group. They couldn't really. So they couldn't really force these patients to be randomized. So some patients decide what they wanted to do. So some patients are, patient choice group. And you can see that, the majority of them wanted PCI over CABG. And then there's another group, which is the physician-directed group, where one of the operators felt that, there was no good revascularization option. So the patient was referred back to their cardiologist or PCP, and eventually have, in-depth discussion about how they wanted to get revascularized. So that's that particular group. I think, the focus is really on this randomized group because, this is a randomized clinical trial. And you can see that in-hospital death, was higher in the repeat CABG group compared to the PCI, where there was 6 deaths compared to 0 death. And this number is consistent across other groups as well. In the physician-directed group, there was 13 deaths compared to 2 deaths. And then in the patient choice group, there was 5 deaths compared to 0 death. The authors also look at sort of the short-term survival of these patients. And in general, the authors conclude that the short-term survival is generally the same across the group. In the randomized group, cabbage population had a slightly higher, lower chance of survival compared to the PCI group. But that kind of evens out after 3 years or so. So this is long-term follow-up. And the 36-month survival, 73% had survived and 76% in the PCI group. And then in the physician group, the same thing here, 71% in the cabbage, 77% of PCI. What's interesting in that in the patient choice group, there was actually a lower chance of survival for those who chose cabbage over PCI. And I don't know if there's a good explanation for that, to be honest. So other than that, secondary endpoint wise, besides survival, the author looked at sort of survival free from unstable angina, repeat revascularization. And generally they found that if you're able to survive redo cabbage, then you have a higher chance of kind of getting more benefit from it, right? And this is something we see consistently for cabbage in general. So, patients who survive cabbage have a higher percentage of freedom from either unstable angina or repeat revascularization compared to the PCI group. Okay, so that's the awesome trial. So this is another trial. It's a little bit more modern, which compared, again, repeat cabbage versus PCI in patients with prior cabbage. And it kind of arrived at a different conclusion. So the Awesome trial showed that the survival, long-term survival, at least out until 3 years, was similar between repeat cabbage versus PCI. This trial shows that actually, repeat cabbage showed a better survival than PCI. So it's a retrospective study. It's a small trial. It's not randomized. It's retrospective. And it's, in a sense, more contemporary than the Awesome trial because most of the time, second generation drug-eluting stents were used and distal embolic protection devices were used. Whereas in the Awesome trial, those technologies were kind of still being adapted at that time or they didn't come out. So what this graph shows is that those who kind of undergo PCI have a lower chance of survival than redo cabbage. There is an early mortality rate with cabbage, but after 1 year, so that repeat cabbage generally becomes more superior to PCI in general. The study also kind of differentiates between PCI to the native artery versus PCI to grafts because there is a difference. So generally, PCI to the graft do worse than PCI to the native arteries. So what is the most current recommendation in terms of guideline regarding repeat cabbage versus PCI? So, one thing that we kind of didn't address in really either of those studies was the presence of whether or not you have a IMA conduit that's available, right? And whether or not, which territories are ischemic. So it's generally thought that, if you revascularize an ischemic LAD territory with IMA, that's really kind of your gold standard in a sense. So the revascular guideline says that, you can consider redo cabbage if there's ischemia in the LAD territory, especially if an IMA conduit is available. And you can also consider repeat cabbage in more complex multivessel coronary artery disease. Instances where you would consider PCI over repeat cabbage is in the setting of ACS. If there's a focal SPG lesion that's amenable to revascularization. And and importantly, if the native vessel is suitable for PCI. So, other practical considerations obviously include patient-specific factors such as age, comorbidities, patient preferences, and sometimes ejection fraction is taken into account. So it really is a very in-depth heart team approach. Um, and you can kind of see that bear out, especially for the fellows when we do CAF conferences at the VA. We oftentimes talk about situations like this. So regarding native vessel versus graft PCI, so we talked a little bit about that in that, one particular Mayo Clinic trial that we showed where native vessel PCI was superior to graft PCI. So there's recommendations about that as well. So the American guidelines states that PCI of the native artery should be considered over PCI of the bypass graft when feasible. And the ESC guidelines generally the same. The level of evidence is between B and C because a lot of these kind of recommendations are from observational retrospective studies, and they oftentimes tend to be pretty old studies. So we'll talk more about this. So, most evidence on native vessel versus bypass graft PCI, like I mentioned, comes from observational retrospective study. This is a VA study, another VA study that took place from 2005 to 2013. They looked at quite a large cohort of patients. And overall, there were 11,000 patients who had prior CABG. And so they looked at these patients and they looked at whether or not their native vessels were treated versus their SVG versus arterial grafts. The arterial graft comprised probably only 1.5%, obviously because IMA graft tend to survive forever. So the author found that in general, patients undergoing bypass graft PCI had higher in-hospital mortality compared to native artery PCI. So 1.79% versus 0.83%. There was a higher rate of no reflow phenomenon at 3.37% versus 0.4%. And there was a higher rate of periprocedural MI in general, 1% versus 0.43%. This graph shows the long-term result of vein versus native vessel PCI. So long-term wise, compared with native vessel PCI, vein graft PCI was significantly associated with higher incidence of major adverse events, including death, MI, or repeat revascularization. One thing I should mention about this study is that the cohorts are not altogether the same, especially in the vein graft population. The authors found that they were generally older and more likely to have comorbidities like diabetes and chronic kidney disease. So that can skew the data a little bit. This is another study, and it shows similar findings where they demonstrated that native vessel PCI is better than graft PCI. It's a smaller study, retrospective of 161 patients who had prior CABG undergoing PCI. What's a little bit different about the study is that a significant percentage of patients had ACS. On the other hand, more of the ACS presentations were in the group that had PCI, the vein graft, compared to native vessel PCI. So, like I said, unlike the previous study, this was a much smaller study of 161 patients. There was a sizable number of ACS patients. And unlike the previous study, there was no significant difference in terms of the patient's age, gender, BMI, and other risk factors. So the main finding of this trial is that the target vessel revascularization rate was significantly higher in the graft PCI group. almost about threefold higher. When you talk about absolute kind of risk reduction, then it's about 10%. And in general, no reflow occurred at a much higher rate compared to native vessel PCI. Other kind of stuff to mention about this trial, drug-eluting stent were used in the majority of the cases, and embolic protection device was used in 35% of the cases. So not quite high number. So based on all these observational study, meta-analysis was conducted. This is a large pool meta-analysis cohort of 40,000 patients. And all of these trials, including the ones we mentioned, comparing native vessel versus vein graft PCI. And in general, what the authors found that there was a substantial odds ratio of about 50%. So in other words, you're 50% less likely to experience adverse outcome if you choose native vessel PCI over vein graft PCI. That's quite a significant number. It demonstrates that there's a profound increase in safety and good long-term outcome that's associated if native vessel PCI is feasible. Any questions so far? So despite the better outcome with native vessel coronary PCI, we all know that realistically speaking, kind of at the spur of the moment, the cath lab, grafts are usually the first target that we consider. So there's very reasons for that. First, native arteries can be challenging to recannularize, especially after a number of years out from the initial CABG surgery. So, frequently they're chronically total occluded. And recent meta-analysis shows that CTO PCI of native vessels in prior CABG patient tend to have lower technical success rate and higher contrast in fluoroscopy use compared with sort of regular run-of-the-mill CTO PCI of non-CABG patient. Generally, these patients are older, they have more complex comorbidities and calcified lesions. And oftentimes we take sort of patient factor into consideration. So, these patients, maybe 80s or 90s, perhaps have limited time to realize the benefit of undergoing perhaps a more risky, complex native vessel PCI. So therefore we defer to, fixing the easier of the lesions. Other than that, I would say that in general, there's a lack of randomized clinical trials on the benefits of native versus vein graft PCI, although that's gonna change. So this is a study that's an ongoing trial, probably come out in a few years or so. It's from enrolling patients in about 3 years. The primary endpoint will tell us whether or not there's a difference between native versus vein graft PCI. So this is a trial that takes place in Netherlands. Patients are eligible for inclusion if they have a significant diameter stenosis in an SVG and a clinical indication for PCI. And also as well, obviously, both graft and native vessels are deemed feasible for PCI. The exclusion criteria are cardiogenic shock, ACS, and heavy thrombus burden. And I had to kind of look that up. What they meant by heavy thrombus burden was there's greater than 50% of bypass lumen that's stenosed and greater than 2 out of 3 segments. So greater than 2 out of 3 proximal, middle, or distal segments. So you have 2 or more of those, then they were excluded from the trial. So they'll do follow-up angiography in 1, 3, and 5 years. And the primary endpoint is sort of composite MACE at 3 years. So it'll be interesting to see what the results of this will be when it comes out, and whether or not it will be practice changing. Because I feel like a lot of people kind of adapt kind of their own style doing interventions when it comes to vein grafts. And so it'll be interesting to see what happens when this trial comes out. So, after all of that, we decided that we're not going to do repeat bypass, that we can't do native PCI because it's too complex. It's CTO, it's calcified and whatnot. And we're stuck with sort of the vein graft interventions. So what are the stuff that we have to consider? Um, so we know that in the early days of vein graft PCI, pure balloon angioplasty had a very high rate of restenosis. So it's so high that you can almost expect less than 1/3 of patients to remain event-free after 5 years if you just do POBA alone. Some predictors of restenosis. In general, the younger the graft at the time of intervention, the greater the procedural success and the lower the rate of restenosis. Um, it's also been found that aortal osteal lesions tend to restenose more than distal anastomosis. So, quickly with the advent of bare metal stent, people were hoping that the superior outcome of stents in native coronary vessels would translate over to vein graft PCI. So long story short, that sort of turns out to be generally true for both bare metal stents and drug-eluting stents, but not to the extent that people would like. So the first seminal trial was the SAVE trial, and they compared bare metal stent, so state of the art at the time, versus pure balloon angioplasty. So there were 220 patients. They were randomized into either bare metal stent versus balloon angioplasty. So you can see from this graph that initially at baseline, the degree of initial luminal narrowing was similar between the two treatment groups, as demonstrated by sort of the near superimposition of the curves at baseline. So after the procedure, there's a greater luminal gain in the stented group compared to the balloon angioplasty group. And this curve continues to be separated after about 6 months, sort of indicating a larger luminal diameter gain achieved by stent placement. Other stuff to note, which I thought was interesting, is that the late loss of luminal diameter was actually higher after stenting compared to the balloon angioplasty group. And it's a little bit hard to know exactly why, the practice at a time, whether or not, obviously people weren't using IVUS all that much. And, whether or not there was this kind of emphasis on, expanding the stents is lost in sort of the details.
The answer to that is no. Nobody did IVUS to maximally expand stents.
Yeah, that's right. Yeah. So what about bare metal stent versus drug-eluting stent? So this was one of the first trial that came out that compared the two types of stents. It's a very small trial of only 75 patients. They were equally randomized into either one of the arms. You can see here that the primary endpoint in terms of instant luminal loss was, greater in the bare metal stent compared to the drug-eluting stent, but not to a significant degree. The target lesion revascularization, however, the percentage is a lot more different, 5.3% in the drug-eluting stent versus 21.6% in the bare metal group. So at 3 years follow-up, interestingly, the drug-eluting stent had more depth than the bare metal stent. That's probably because the patient population was small in size and they weren't really powered for clinical events. But it's interesting to note that there was a higher number of deaths in the drug-eluting stent compared to the bare metal. So the problem with the previous trial that I presented was that it was, underpowered for clinical events. So these are the three sort of more substantial trials that I summarize in each of the columns. The ISR Cabbage, Basket Savage, and the Diva trial. So the ISR Cabbage study is the largest randomized controlled trial performed to date in vein grafts, comparing first generation drug-eluting stent versus bare metal stent. Uh, and it showed that there is a statistically significant difference in MACE at 1 year, so 15% in the drug-eluting stent versus 22% in the bare metal stent. And that's largely driven by target lesion revascularization at 7% versus 13%. Importantly, there was no statistically significant difference in all-cause mortality, MI, or stent thrombosis. And importantly, at long-term follow-up into 5 years, there was actually no difference in the endpoint. And in fact, there could have been a signal for access of target lesion failure in the drug-eluting stent. Bear in mind, this is first-generation drug-eluting stent. So the Basket Savage trial arrived at a slightly different conclusion in terms of its long-term outcome. So at 1 year, the MACE was lower in the drug-eluting stent, and that continues to be true for 3 years at 12% versus 30%. And then after 5 years, there was persistent benefit of drug-eluting stent over bare metal stent. The DIVA trial is the most modern of this trial. In a sense, it's a little bit more contemporary, and it uses embolic protection devices 69% of the time, which is pretty good. And second generation drug-eluting stent comprise 88% of the population. So importantly, they did not do routine angiographic follow-up. So a lot of the sort of repeat PCI revascularization was just driven by clinically relevant event. And this trial shows that there was no real difference between bare metal versus drug-eluting stent, 17% versus 19%. There was no difference in secondary endpoints in terms of cardiac death and myostent thrombosis. Their long-term follow-ups a little bit shorter, median of 2.7 years, and there was no statistically significant difference in terms of target vessel failure. So, why is drug-eluting stent, not as promising in vein graft PCI as compared to native arteries? And it's generally thought that the problem with drug-eluting stent in vein grafts is that re-endothelialization takes even longer. So it leads to higher rates of uncovered stent struts. So this is a interesting pathology slide on a patient in their 80s who passed away. And so this is an autopsy. And this patient had drug-eluting stent placed 2 years before their death. So each of these are cross sections. So these are two stents that are overlapping one another, and there's cross section A, B, and C. So you can see in A that this red line here is the fibrous cap of this particular lesion, and the asterisk is the stent struts. So the stent struts has disrupted the fibrous cap here. And then in this particular area, you can see that the stent struts are just kind of laying on the surface of the vessel with some thrombus, a significant amount of thrombus covering it. And the same with here in the distal portion of the stent where, there's thrombus covering the stent struts and generally a lack of endothelializations of this stent. So, we talked a lot about, the intrinsic features of the vessels and, the next kind of technology that naturally came up was embolic protection device. So I just wanted to finish this talk on this topic. So the 2011 guideline gave a class 1 indication. And that's primarily, it's based on a single randomized clinical trial at the time, which we'll talk about. The updated, 2000, most recent 2021 guideline about protection device took a more conservative stance with the class 2A recommendation. So here are some embolic protection devices. The guard wire is no longer available in the US. And maybe some of you in the audience might know, but I have trouble finding out why it was discontinued in 2017. Wondering if anyone knows if there's a particular reason why. But the majority of the embolic protection devices we use are the filter wire and the spider. It's still relevant to mention the guard wire because it was the first commercially available device that came out in the US. And it was the first that, was a randomized trial was conducted on. So just to explain the guard wire, it's a distal balloon occlusion device. And, some people in the audience might know this more than I do, but basically, a distal balloon is passed beyond the lesion and then inflated and includes the distal portion of the SVG. And then you can start intervening upon the particular lesion with a stent, angioplasty. And then after that, you finish it off by passing an port aspiration catheter to take out, the thrombus. And then you deflate the balloon and take out the system. I don't know if anybody's used this device.
Yeah, myself and Dr. House had lots of experience with it. Did you use it, Tim?
I did. It was hard.
Yeah.
Yeah.
The place to stand
It's
blind.
basically just block the circulation and then you have to aspirate. The problem was aspirating everything and something gets caught, in between the balloons. So you can't retrieve everything that all debris that embolize this stuff.
Plus, you had the
Yeah.
place to stand blind. We couldn't inject contrast when you were putting the stent in. So sometimes you hit it, sometimes you didn't.
Say this.
Right.
Yeah.
There's a much longer stance, not misleading.
Yeah.
As Satara likes to say, the dark days of angioplasty.
Yeah, so, despite what you guys may think, the safer trial showed that the guard wire was actually effective. So, so there was a 6.9 absolute reduction in the 30-day primary endpoint when it comes to MACE with the use of guard wire compared to, no use of the guard wire. And this is driven by reduction in no reflow and periprocedural MI. So, interestingly, once a trial like this comes out, it kind of becomes unethical in a sense to compare other devices with another group that, don't have the device. Because, obviously it becomes very unethical to deny patients the benefits associated with embolic protective device use. So subsequent trials basically have been non-inferiority trial comparing themselves with the guard wire. So this is a FIRE trial which showed the effectiveness of the filter wire, and across all sort of endpoints that they looked at, there was no statistically significant difference between the filter wire and the guard wire, thus demonstrating non-inferiority of the filter wire. So that's all I have. I've kind of gone through some data, some histology slides, and just kind of generally covering considerations for vein graft PCI. And so my take-home points is that, knowing the bypass anatomy is important in our day-to-day practice in the cath lab. Obviously fluoroscopy and, use of contrast is always an issue. So knowing your anatomy is important. We talked about how vein grafts have a unique biology, which accelerates their attrition rate. We also talked about how PCI is oftentimes favored over redo cabbage due to procedural mortality. But that's not necessarily all the case all the time, and certain trials show perhaps similar survival. especially when you're considering, considering favorable anatomy, particularly the availability of IMA and LAD territory ischemia. And then I also talked about how native vessel is favored over bypass graft PCI, but this may not always be feasible. And then we talked about techniques and strategies associated with vein graft PCI in particular. You can potentially use just POBA in young vein grafts at an anastomotic site. The rate of restenosis for that particular location tends to be a little bit less. Bare metal stent is in general superior to balloon angioplasties in most instances. And then we also kind of talked about the promise and shortcomings of drug-eluting stent.